So, good evening, one and all. Today, we will be discussing about the Tiva and the TCA models. These have taken over this present era where most of the corporate hospitals they do most of the surgical procedures with propofol and remipatinil TCIs, and patient wakes up like as if they have not undergone any surgery at all. So, that is where the present era is heading. And it has become a very important topic to know also as both practical and theoretical point of view. So when do you call anesthetic service as device? It is a total intravenous anesthesia wherein you describe the maintenance and induction of anesthesia with a intravenous agent without an inhaled hypnotic. The inhaled hypnotic can be nitrous oxide or whatever fluorines which we use in our day-to-day practice, may it be desflurane, sevoflurane, or isoflurane, whatever fluorines you use. You need to maintain the anesthesia without the use of these IV hypnotic agents. And this it can be done either with the use of single drug or combination of drugs can be used, as like when you give a propofol induction and you maintain the anesthesia with propofol and remifentanil titrated basis. So it can either be a combination of single drugs which you use to maintain the anesthesia with, or you use a combination of drug. So there are definitive indications in the literature for using a total intravenous anesthesia, wherein the use of muscle relaxants or the use of inhaled anesthetics is like contraindicated, or it is like to be used with caution. So the indications will be malignant hypothermia. So when you use succinylcholine along with sevoflurane, so you have got a risk of malignant hypothermia. So any patient who gives a history of a familial malignant hypothermia risk, or in whom there was a familial history of malignant hypothermia, be very cautious about giving these inhalational agents and muscle relaxants together. So in that patient, Tiva is indicated. In whom there is a long QT syndrome, there is a severe history of postoperative nausea, vomiting. When you want a tubeless ENT or thoracic surgery, you want the patient to be spontaneously breathing, but then the patient needs to be tubeless also, and the surgeon wants to go forwards. Then at that point of time, you can do a Tiva. And patients with anticipated intubation as well as extubation, when the patient is undergoing a surgery with neurophysiological monitoring, when the patient has got a myasthenia gravis or any neuromuscular disorders wherein you will think that you have to avoid a neuromuscular blocking agent, and in non-operating room anesthesia, wherein you want a clear-headed patients at the end of the procedure, and when you transfer the patient between environments wherein your inhalational agents may not be available, as an anaconda device which is used in ICUs that may not be available when you transfer patient all the way from an ICU to any endoscopy suite or any MRA suite. So that point of time you can administer Tiva and daycare cases, and if it's a patient's choice. And what are the considerations which you will think you have to get going when you are actually thinking about these Tiva is a pharmacodynamic property of the drug and pharmacokinetics properties of the drug, and what is the effect that the drug is producing in the body. So what are we talking about? Pharmacokinetics is when you give a particular drug, what is the drug, what is happening to the drug in the body. So whenever you give particular drug, you want to achieve a therapeutic concentration in a desired time. Say you are giving a bolus amount of drug right now, and you are going to expect an outcome or an effect after 30 minutes. That's not going to be a hypnotic, because you want everything to be fast tracked. So within a desired course of time, you need to achieve a therapeutic drug effect, and that drug effect should not have any dose related side effects, and the patient should have a rapid onset and rapid offset. Both onset and recovery should be smooth and easy. So this is the pharmacokinetic properties you are expecting whenever you are giving a Tiva with a particular drug. So is it possible with a single drug? Do you think it's possible with a single drug? No, that may not always be possible with a single drug, because if you give a single bolus of a drug, you suppose it says a surgery is going on for 1 hour. If you're giving that kind of drug at one point, what amount of drug will you require to produce an effect for 1 hour, provided the T of the drug is only 9 minutes or 10 minutes? The effect is going to fade off. And to produce a therapeutic concentration of such concentrations for a very long time, you will need a very, very higher dosage. So at that point of time, it may not be possible for you to administer a single dose and expect a response until the end of the surgery. So with a single dose, that's not going to be positive. And then what will happen if you go for a intermittent bolus? Can you give an intermittent bolus and tide over the crisis of giving the drug or maintaining the therapeutic concentration? So whenever you give the drug as an intermittent bolus, so this is a drug which is given as an intermittent bolus. As you can see, whenever you give an intermittent bolus, the concentration, the yellow one is the plasma concentration and blue one is the effect site concentration. The effect site here is basically the brain for any inhalational or intravenous agent. So there is going to be a spike and then fall. There is going to be a spike and then fall. So the plasma concentration, say 2 mics, 4 mics, 6 mics. Normally you're expecting a plasma concentration of propofol, say around 3 to 4 micrograms per ml of propofol to maintain a therapeutic effect. But here when you see the plasma concentration spiking to 14, then dropping to less than 2. Spiking to 14, dropping to less than 2. So what will happen is there will be a spike, then fall below the therapeutic concentration, spike, fall below the therapeutic concentration. This spike is associated with hemodynamic diseffects like side effects like hypotension, bradycardia. This fall is associated with inadvertent awareness. So this also is not a best way to give any total intravenous anesthesia. So the same is replicated here. There will be a spike and then fall. So you may not have a adequate concentration of propofol in the blood to have a effect that will produce decrease in the EEG or decrease in the BIS values that will sustain for a very long time if you give intermittent bolus. So what is the only solution when you have a Tiva which you have to administer is you always have to give a bolus followed by continuous infusion. So why do you have to administer a bolus is if only you say you keep an infusion for somewhere around 10 milligrams per kg per hour of propofol, the infusion alone will take a longer time to achieve these therapeutic concentrations. So you need to have a spike and then a graph. For this spike to happen, you need to administer a bolus. Suppose you say you have kept a infusion alone. This is time in seconds. So it is happening somewhere around, say, 100 seconds, or the rise in the plasma concentration is happening somewhere in 100 seconds. That should happen faster, isn't it? Say, suppose you have not given any bolus, means if you have kept only infusion, for the propofol to come to the level of therapeutic concentration, it will take somewhere around 35 minutes to 40 minutes for it to equilibrate and come to a level of therapeutic plasma concentration. So whenever you administer any drug in Tiva, always give bolus followed by continuous infusion, because continuous infusion will take very, very longer time to achieve the therapeutic plasma concentration. So there are pharmacokinetic models which are there in place. Whenever you see this pharmacokinetic model, there will always be, whenever you give a drug as a bolus, it will follow an exponential decline in 3 phases. One, when they give you a drug, it will follow the central compartment and then it will dissipate into the well-perfused muscle compartment and then to a less perfused compartment. So whenever you give a drug as a bolus, there will be an exponential decline in the concentration of the drug and it will follow the central compartment, and the central compartment will have elimination as well, and then the well perfused compartment, and then the compartment which is fat, that will have a prolonged excretion time also. So any pharmacokinetic model which is used in Tiva will follow the 3-compartmental model. So what is the 3-compartmental model is, whenever you give a bolus of a drug, there is a central compartment which is the blood and the first pass pulmonary uptake that will form the central compartment. From the central compartment, the drug will first pass through a rapidly equilibrating compartment which consists of the splanchnic and the muscle tissues, and then to the slowly equilibrating compartment which is the flat stores. So there is always a intercompartmental communication from V1, whatever the amount of drug which is going to V2 will follow a constant of K12, and from V2, whichever drug is returning to central compartment will follow a constant of K21. The same goes for central compartment. So to the slowly equilibrating compartment, the drug passing from central compartment to slowly equilibrating compartment will have a constant of K13, and from here it is K31. And you also need to understand that there is a Ke0 or Ke eta, which is the constant which is going for the effect site. This has got a very, very important role in the Tiva and the TCA models, and you should always have a concern about Ke0, which is the effect site concentration constant. And K10 is the elimination rate constant. So elimination rate constant will encompass all the drug which is undergoing biotransformation or elimination. This particular amount of drug is irreversibly eliminated from the body as well as from the central compartment. So there is no longer the drug which is passing through K10 will no longer be able to return to the central compartment because those drugs are completely eliminated. So these are about the intercompartmental rate constants. And so what are the pitfalls of this pharmacokinetic model is it assumes that the bolus injection is completely mixing with the central compartment at the time 0. But what happens in reality is it takes at least 30 to 45 seconds for the drug to circulate to the whole body. So the peak concentration is never achieved at time 0, but it is in fact achieved at 30 to 45 seconds later, may it be plasma or effect site. The effect site still takes longer. So this is the pitfall of this pharmacokinetic model which we are working. But at present, there are also models which are using time lags and finding out this compensating for this lag which is attributed in the initial systems. But that is beyond the scope of this lecture, so I'm skipping it. So the next thing is the pharmacodynamic properties. So what is the pharmacodynamic property is what is happening in the body with the drug. So that is a biophase or effect site. So what is the biophase is the stable concentration, therapeutic concentration of the drug that is happening at the site of drug action. So the site of drug action is the effect site. What concentration of the drug which is reached is the effect site concentration. So what happens next is the effect site and the hysteresis. So most often than not, we think if the drug has reached plasma, then the drug will start to act. Yes, it will start to act only when it is reaching the effect site. So is plasma the effect site for all the inhalational as well as the intravenous agents? No, the effect site is the brain. So what happens is there is a time lag between the peak plasma concentration and the peak effect site concentration or the peak brain site concentration. Why this happens? The drug has to dilute in the central compartment. It should reach the brain or the effect site, whatever may be. It should go cross the membranes, bind to the receptor, elicit a cellular response. From there, it should elicit a hypnosis or whatever it's supposed to do. So this time from where it is entering the blood to the effect site, to the cellular component, to the binding receptors, eliciting a change in a GABA receptor, and then producing hypnosis, there is definitely a time lag between the plasma concentration, the peak plasma concentration, and the peak effect site concentration. And this lag is called the hysteresis. The concentration which is there at the effect site is called the biophase or effect site concentration. The time lag between the peak plasma concentration and peak effect site concentration is called as the hysteresis. So here is the graph of, so this is the bispectral index and this is the propofol concentration. The yellow is plasma concentration and blue is the effect site concentration. So as you can see with time in minutes, when the peak plasma concentration is reaching somewhere around 12, say that it has reached 10 at the time 2.5. But you see at the time of 2.5, there is no effect site concentration at all corresponding to this point, isn't it? This is the effect site. So at this point, when it is starting to rise at the peak, there is no effect site concentration. The effect site concentration is literally 0 here. It has come only to 2 or 3 here when it is reaching 10. So there is definitely a delay between this concentration and this concentration. So this delay or the difference between these two is called as the hysteresis. So as you can see, it is peaking somewhere around to 10 or 12 micrograms per ml here, and the corresponding level of effect site concentration is somewhere around 7. So there is definitely a lag between the peak plasma concentration and the effect site concentration. So the same happens with BIS. So the BIS should fall when your concentration of propofol is rising. See, when the propofol concentration is somewhere around 12, the BIS effectively stays at 60. So that's not even in the range, isn't it? Only when the effect site concentration rises to somewhere around 4 nanogram per ml will then the BIS start falling. So at least it should reach around 2 nanograms per ml for the BIS should start falling. For a proper general anesthetic level, it is coming at the level of 40 and around only when the peak plasma concentration is reaching somewhere around 4 to 6 micrograms per ml. So there is definitely a delay between the peak plasma concentration and the effect and the BIS that is happening at the level of the brain. So that you need to consider. The same thing which is given here. So this is the plasma concentration. This is the effect site concentration. The yellow dot is the effective effect site concentration. And this is the sigmoid regression of the propofol concentration per ml. So this is the propofol concentration. Only when the effect site propofol concentration reaches somewhere around 2 or so will then the BIS start falling. Else the BIS never starts to fall. So there is always a lag between the plasma and the effect site concentration. And what are the pharmacodynamic models which we are using at present is a direct effect model and an indirect effect model. So you just need to know the names of both which are happening. So what is the dose which is implicated or dose implication which is happening is the effect site concentration at the start when you give any drug is a concentration 0. So the concentration will increase as and when you increase the plasma concentration of any drug. You need to consider that there is always a time to peak effect of each of the drugs which you're using. So in case of morphine, it is around 19 minutes. So that is why you give morphine prior to induction, or whenever they give us a pre-medication, they'll give it 1 hour prior. Why is it so? Because it will need at least 20 minutes for morphine to have its peak effect. May it be an analgesic effect, so it will need at least 20 minutes for it to act. So before 20 minutes, you cannot say morphine has started to act. And it will act, but the peak effect happens only when it is 19 minutes. The same for fentanyl, it is somewhere around 3.6 minutes or 4 minutes. And for propofol, it is 1.6 minutes. And etomine, it is around 2 minutes. So you need to have this in concern when you are giving any particular drug, because the peak effect will happen only after the particular time has evaded for any drug. So there is always a measure as to how we are measuring this drug potency. That is the MAC, which we will use in the inhaled anesthetic agent. So the concentration, minimum alveolar concentration, which is necessary to prevent a response into a noxious stimuli or a supramaximal stimuli, is called as MAC. The same thing is C50, which will determine the relative potency between the intravenous anesthetic agents. So what is C50? Is the drug concentration that will prevent response in a particular, for a particular stimulus, may it be intubation or a surgical response, in at least 50% of the patients. So what are the drugs which we use in propofol, TCI or Tiva is the most commonly used drugs are propofol and remifentanil, and sometimes fentanyl as well, or alfentanil. So what happens, why we are not using the other drugs is methoxytone, because of its excitatory properties and the EEG changes which are associated, and very long infusions of thiopentone can cause cardiovascular instability and delayed recovery. And for ketamine, for obvious hallucination reasons and emergence phenomenons. And altacin, we are not using because of anaphylaxis. And etomidate, we are not using it as an infusion because of adrenal suppression that will happen for hours. And as induction is equally important, the recovery is much more important, because you're doing it, you want the patient to be discharged as paid care. So what happens when you give as a drug as very long infusion? What will happen to the drug as and when you stop is the concentration, the plasma concentration which was there during the infusion starts to fall. This context sensitivity half time is Half time is from the plasma concentration. When you have stopped the infusion, what was the plasma concentration? The time taken for it to fall to half of the concentration from the time when you stop the infusion is called as the contact sensitivity half time. The concentration should fall half of it. So next came the contact sensitivity decrement time. So suppose if the concentration somewhere around was around 10 micrograms per ml at the stop of the infusion. So suppose it is decreasing to 70 micrograms, then it is decremented to 30%. If it is decreasing to 30 micrograms per ml, then it is decreased to 70%. So 10% decline is 10% fall in the concentration of plasma, concentration in the plasma for a particular drug. So the contact sensitivity half time is now replaced with contact sensitivity decrement time. So 50% decrement time, 30% decrement time, 70% decrement time, like that. So, of note, the one important thing which you should notice, the drug with decreased contact sensitivity half time is the one which is ideal for any Tiva or TCIs. So, remifentanil is context insensitive. The moment, so the blue color is remifentanil, so it is like just lying upon the y-axis. So this is in contact sensitivity in minutes. This is the infusion duration in hours. Even though you infuse for 10 hours, it is context insensitive. The moment you stop, the next minute, the patient is going to wake up. So that is context insensitivity. Then for propofol, as you can see, if you've given as an 8-hour infusion, the context sensitivity is going to be somewhere around 10 minutes or 15 minutes. So again, the patient is going to wake up clear-headed following propofol. So what happens when you use fentanyl is, when you use for more than 4 hours as an infusion, the patient is going to have a very delayed recovery because the contact sensitivity half time is increased. So even in ICUs, if you use, the moment you stop fentanyl, you don't expect the patient to wake up and then respond to you, because that's not going to happen at all. There is always a concept of contact sensitivity half-life. Suppose say you've given an infusion for somewhere around 6 hours, the contact sensitivity half-life is somewhere again going to be 200 minutes or 250 minutes. So that you are supposed to think that the patient is going to be okay only after 100 minutes or at least 1.5 hours has passed. So at least the T off of the drug should come down. I mean, T off of the drug should come and elimination should happen. All these things has to be acting in simultaneous so that the drugs will get eliminated. Only if the drug is getting eliminated and the concentration is coming down, will then the patient breathe spontaneously or respond to you if you're giving it along with a dose of midazolam. So again, for midazolam, it is not as high as fentanyl, but still, as you can see, this yellow one is the midazolam. So midazolam has got a contact sensitivity somewhere around 50 to 100 minutes. So you need to know the drug and its property to maintain the Tiva and TCI. So the infusion techniques and TCI models. So as I've discussed before, Tiva is just the administration of anesthesia via an IV route for both induction and maintenance. But what is a TCI is, that is using a pharmacokinetic model to maintain a steady state concentration. May it be effect site concentration or a plasma site concentration. You use it along with an infusion device. So the delivery of IV agents to achieve a total intravenous anesthesia is aided by a TCI. So what is the pharmacokinetic model of a TCI is, it's a bolus elimination and transfer model. So the bolus is given to fill the V1, which is the central compartment, and infusion is given to match both V2 and V3. And K10 is the elimination constant and Ke0 is the constant that is used for the effect site concentration. So the key components of a total target controlled infusion devices are an user interface wherein you will enter every details of the patient, and microprocessors with the pharmacokinetic software, an infusion pump which will deliver up to 1200 mils per hour, and a visible and audible safety systems and alarms. So the pharmacokinetics which you use is drug which is given in the central compartment, and that will diffuse through all the two compartments, and the diffusion of the drug from the plasma to brain will occur exponentially with the first order rate constant of Ke0. So the T half for the process is calculated as T half is equal to log n by into 2 by the Ke0, which is the diffusion constant. So when will the equilibration happen is, it will happen only after 4 to 5 half-lives. And if you want, this is the plasma concentration. When you want to increase the plasma concentration, if you set in the user interface to increase the plasma concentration to 4 to 6 micrograms per ml of propofol, it will give a bolus and then followed by an infusion. Suppose if you want to decrease the plasma concentration, if you go and enter in the interface that you should decrease the plasma concentration from 6 micrograms to 4 micrograms, it will stop the infusion for some time and then keep loading the patient as and when time occurs. So that is how these Tiva and TCA models work. So what is the difference between TCA and a manual infusion is TCI is a target controlled infusion. There is a controlled target concentration and it happens by a feedback mechanism. So this feedback mechanism provides a more dynamic and effective drug delivery system by using a pharmacokinetic as well as dynamic model that will keep adjusting the dosage of infusion constantly. So in manual infusion, it is the work of the operator to determine the dose at which the patient should get, and it will be given to the patient as and when the operator is changing the infusion dosages. Then, so there is also two types of TCI, which is an open TCI and a closed TCI. So closed loop TCIs, what happens is it takes control from the BIS value and it adjusts the drug which is given accordingly. So this closed loop will avoid the clinician to titrate the target concentration manually. There will be a continuous measure of the drug which is happening based on the BIS values, and because of that there is an automated drug delivery which is happening. So the user need not enter anything. If you set this this much of BIS should be maintained, it will take whatever amount of BIS values is there and then titrate the drug accordingly to maintain the BIS values and close the loop. And that is about the closed loop TCIs. So next is the infusion techniques or manual infusion techniques. So the first one of which we will see is the propofol infusion technique. That is a manual infusion for propofol, which is a Bristol-Roberts regime. So this can be used whenever you don't have a TCA pump in place. So what happens is you give a bolus of propofol, that is 1 milligram per kg. Next, you administer a dose of 10 milligram per kg per hour for the first 10 minutes, and then 8 milligram per kg per hour for the next 10 minutes. Then 6 milligram per kg per hour thereafter for till the end of surgery. So what are we supposed to aim is, if you titrate it like that, they have found from studies that in most of the patients this may correspond to 3 micrograms per ml of propofol dosage. So this concentration may not be appropriate. So this may be inadequate in some, or this may be overshooting in some. So when you administer it along with other potential confounder agents like fentanyl, or if co-administered with morphine, then again that can confound the hypnosis which is taking place in any patient. Suppose if the patient is somewhere around 60 kgs, you give 60 milligrams as bolus, followed by 10 milligrams, 600 milligram for the first 10 minutes, then 60 into 80, 480 milligrams for the next 10 minutes, and then 360 milligrams per hour thereafter. That is how you do it. So you set in the infusion pump. So 360 milligrams means you should have 36 ml per hour. So that is how you set the whole infusion pump per se. But is it without side effects? Yes, it is with side effects or potential pitfalls. There is no clear-cut indication of the dose which is delivered. Suppose if you are held up somewhere, like during the induction, you are having encountering an airway difficulty after you have intubated, the tube has come off, something like that. If you fail to change the dose of the drugs in the 10 minutes, 10 minutes, 10 minutes, the patient is either going to be like too under or too light. So that is going to happen in manual infusion techniques. So there is no effect site of plasma concentration which is displayed. We assume that it will be 3 micrograms per ml, but it is never true that it is 3 micrograms per ml for all patients. And you need to frequently change to maintain the steady state concentration. And if you want an increase in plasma concentration at any point of time, you need a bolus. If you have to decrease the plasma concentration, you need to stop the infusion for some time. And this is not very well validated in any pediatric patients, and it is not useful also in pediatric patients. So all these are the other manual infusion schemes which you can use for anesthesia as well as sedation or analgesia. So in anesthesia point of view, as you can see, you can give a propofol loading dose of 1000 micrograms to 2000 micrograms. followed by 50 to 150 micrograms per kg per minute as an infusion. Suppose if you want to give us only for sedation, you will see the bolus dose is decreased 25 to 100 milligrams, and the maintenance will be 10 to 50 micrograms per kg per minute. So this tabular column is there in Miller. If you want to go through, you can go through. So next is the coming to the models of TCI for propofol and remifentanil and alfentanil which we are using. The first one is the Marsh model. It is the simplest model which was developed. It is adapted from Goetz's three-compartmental pharmacokinetic model, and all the drug which is delivered via a Marsh model will have the scalar as body weight. So based on body weight only, the dose will be delivered. So there is also modified Marsh model, and maximum accepted weight up to which you can use a Marsh model is 150 kgs. In Marsh model, you can very well go for effect site concentration. So since body weight is used as a fixed scalar, so the same dose which is administered for 60 kgs 20-year-old is also administered for 60 kg 90-year-old. But 90-year-old pharmacokinetics is not the same as 20 years old. So this dose may be an excessive dose in a 90-year-old 60 kg patient, and that may cause hemodynamic instability. Because clearance also is coming down, the plasma concentration is usually underestimated in elderly in case of Marsh model. And elderly patients, they are pharmacodynamically more sensitive in terms of cardiovascular systems and respiratory systems to propofol. So that's one of the main pitfall. So if you want to use it in an elderly frail patient, you need to be very, very cautious. So the same thing happens with obesity. So the V1 in obesity patient is not significantly increased. And this total body weight will need a very large bolus, and the maintenance bolus will be whatever you're giving is greater than that of the requirements. So they've given a formula like Servin formula and Lemon's formula for calculating the ideal body mass and then administering the drug. So that is again one pitfall. The second one is the Schneider model. It has been taken in a single set of 24 volunteers. You need to enter height, total body weight, age, gender, and lean body mass. In Schneider, what is taken as a scalar is age is taken as the scalar. So any patient in whom who is frail, in whom you don't want a better, you want a hemodynamic stability, in whom they are so frail that even low dosages of Schneider will suffice for the patient, and you can go for Schneider. So the V2 will depend upon the age, and V1 and V3 are fixed. So again, what happens, what is the pitfalls in Schneider is, this is one graph which you have to take into account. So this is the total body weight in kgs. So 0, 20 kg, 30 kg, forming 40, 60, 200 kgs. So this is the lean body mass. So as you can see here, up to certain point of weight, say 80 kgs, the lean body mass is increasing when the weight is increasing up until this point here, up until this point here. After some point of time, this total body weight, if it is increasing, the lean body mass decreases because the remaining everything is a fat, isn't it? So the lean body mass declines. So for 180 kgs, the lean body mass is somewhere around 30. For 80 kgs, the lean body mass is somewhere around 40. So the lean body mass will vary inversely with body weights and heights. So for a 180 centimeter, 200 kgs, the lean body mass is somewhere around 35 or 38. So that is how it goes. But for somewhere around 180 centimeter, 100 kgs, the lean body mass is 60. So the lean body mass varies inversely with the total body weight. As I've told earlier, this K10, which is the elimination constant, is very important. So K10 will vary directly with the total body mass and inversely with the lean body mass. In any morbidly obese patient, because of the paradoxical decrease in the lean body mass, it will cause the K10 to increase, and you will require a very large bolus to attain a plasma concentration. Hence, the required infusions will increase exponentially, and when the infusions are increasing exponentially, you will need a very, very larger boluses to achieve a therapeutic concentration. that may produce a hemodynamic instability. So, in order to mitigate this problem, in order to clear this problem, the TCI models do not use this downward trending of the lean body mass anymore into the consideration. It uses only this peak level which is there for a particular weight. Suppose say 200 kgs. In this 200 kgs range or 160 centimeter, 180 centimeter range, whatever is there at the nadir, somewhere around, say somewhere around 50 to 60, that will taken as the lean body mass, and not 30 or 40. If it is taking 30 or 40 means the drug delivered will be too high and the patient will have hemodynamic consequences. So this is one of the very important thing which you have to note. As the total body weight increases, the K10 will increase. So as the total body weight increases, the lean body mass will get to decrease. When the lean body mass decreases, the K10 will increase. So this is again a tabular column showing what is the cumulative amount of drug which is there in the plasma, as well as like in the plasma when you use a plasma site concentration or an effect site concentration. So in a modified Marsh formula what is happening is when you use a bolus, it is for like standardized patients, 70 kgs patients, so bolus is 86, which Schneider you will have only 18 milligrams as bolus. And to time to equilibrate will be larger for that of Marsh plasma site concentration. And the cumulative dose, as you can see, is somewhere around 360 milligrams. At the end of infusion, it is 570 milligrams. Again, the dose is actually very less for that compared to Marsh, the dose is less for Schneider. The same goes for effect site concentration. If you use effect site concentration, the Marsh model may have an initial higher level of initial dosing and further will have same sustained effect. And for Schneider, the effect site concentration uses a higher dosages than the plasma site concentration, but cumulatively the dose will reach the same when compared to Marsh. When you're comparing Marsh and Schneider, the dose will always be lesser in Schneider compared to Marsh model. Okay, so this is just for the dose comparison. So next is the Eliveld model, that is a hero model, which is a universal model, which is studied using 21 studies using 660 patients, where they've collected somewhere around 10,000 samples for analysis across all age groups, may it be from neonates to elderly as 88 years. They have found that this system is holding good for all the patients in whom you are using. So from normal weight to obese individuals, from 5 to 160 kgs, nothing like Eliveld, you can go for it. So the pKa is you need to enter age, height, weight, gender. This is the only one TCA model which will use presence of opioids as an additional feature. Suppose if you are giving remifentanil as an additional TCI, you need to enter that you are giving remifentanil. So the concentration will be adjusted accordingly. And you can use effect site concentration, and there is a lower effect site concentration initially. So you need to use a bigger bolus at the start. If you use Melville, there will be bigger bolus at the start and lower boluses thereafter. So how can you apply this Eliveld model for neonates as well as elderly patients as well as obese patients is this uses a theory of allosteric scaling. So you can use this formula both for an elephant as well as for a rat. So there is a scalar which is used in the formulas, which is at the dose of 0.75, which is used in the formulas of Eliveld PK model. So what is allosteric scaling is? It is a study of relationship between the size, physical and the physiological attributes. So it is independent of aging and development. The same formula can be used for both elephants as well as for rats. So that is how significant it is because of the presence of a scalar, that is 0.75. So this was achieved by numerous studies. That is beyond the scope of my talk. That's why I'm not touching it. So you need to know the only model which is using allosteric scaling is Eliveld. So suppose you say you're using a target concentration of 4 micrograms per ml in a 180 centimeters, 75 kgs male. As you can see, the plasma Marsh model is delivering a very quite a large dose. The red one is the Marsh model that is delivering a very large dose. The violet one is so the purple one is the Schneider. So this is the purple one. So Schneider will give a low dose when compared to Marsh model always, maybe plasma site or effect site, the dose is very, very less for Schneider effect model. And for Eliveld, as I said, there is an initial bolus dose which is given as a large dose, and then following which there will be a decreased dosage only, even for Eliveld. So that you need to take into consideration. So this is for extremes of age, both underweight and overweight patients. So for Marsh model, when the target is 200 kgs, the plasma concentration, the cumulative plasma dose is exceeding up to 2000 milligrams. For us, an Eliveld target site model, as you can see, here is the Eliveld target site. It is somewhere around 100 milligrams, 1000 milligrams. And for Schneider effect site concentration, so this violet color. So always the dose which is used in Schneider is less, because it is like dependent only on the age. So what is the pitfall of this TCI which you are using is a less evidence of pharmacodynamic model and the Eliveld model which you're talking about, and there is an underrepresentation of 12 to 15 years of age in the population subset where they had studied. So why are we talking pediatrics as a separate thing, separate people is they are different set of patient population. Their pharmacokinetics is different, dynamics is different, and it is totally a different ballgame when you come to pediatrics because of their changes in pharmacokinetics, may it be volume of distribution or drug metabolism. They need a very large bolus dose and they need a subsequently larger infusion doses to maintain the anesthesia because of their pharmacokinetic properties. So in pediatric infusion models, you have two models of propofol. One is a ped fuser, which can be used for ages in 1 to 16 years. It uses Marsh model as a basic model. So 5 to 61 kgs it can be used. The next is a Kataria, which is suitable for 3 to 16 years of age, and the weight shall be 15 to 61. So it targets effectively the plasma site, and time to equilibration has to be kept into concept. So we have seen for propofol in adults, right? The Bristol-Roberts regimen. Is it holding true for pediatrics? So I said no. For propofol, concentration will be reaching somewhere around 3 micrograms per ml if you use 10, 8, and 6 milligrams per kg per hour infusion. So the NADR is somewhere around 3 micrograms. But in children, because of their pharmacokinetic properties, what happens is this becomes a quite an underdose, and the plasma concentration which will be reached is somewhere around less than 2 micrograms per ml. So the child may not be adequately under for the procedure, and the child may have awareness. So you should not use Bristol-Roberts regime in pediatrics. So how do you use them? So pediatric manual infusion formulas are Macfarlane formula, wherein you use a loading dose of around 2.5 milligrams per kg, following which you will use for the first 15 minutes 15 milligrams per kg per hour. Next 15 to 30 minutes 13 milligram per kg per hour. And next 30 minutes to 1 hour it is 11 milligram per kg per hour. And 1 to 2 hours it is 10 milligrams per kg per hour. And 2 to 4 hours it is 9 milligrams per kg per hour. So this again is shown to have a steady state concentration of 3 micrograms per ml for children ranging from 3 to 11 years of age. Again, this is a Stewart regimen. So this is for propofol under 3 years of age. So what happens is, because of the volume of distribution and pharmacokinetics, so the dose administered will be very large dose. A loading dose of 2.5 milligram per kg is used along with the Macfarlane regime. So for 0 to 3 months, as you would see, for the first 10 minutes, you need to keep 25 milligrams per kg per hour as an infusion. For 10 to 15 minutes, 20, 15 to 20 is 20, 20 to 30 is 15. Like that, you need to have a very large doses of propofol for pediatric patients to make them under in TCI. So what are the disadvantages? It's the prolonged contact sensitivity half-life. So in pediatrics, it is 10.4 minutes at 1 hour, and it is it is only 6.7 minutes in adult. The same for 4-hour infusion, it is 19.6 minutes in pediatrics and 9.5 minutes in adult. Provided you're using a very higher dosage to maintain a steady state, it follows that it can have its concomitant hemodynamic instability. So this is about the propofol TCI models, which is a Marsh, Schneider, ped fuser, Kataria, and Minto. So Marsh, as I told, the basis on which the drug will be delivered is the weight. In Schneider, the basis on which the drug will be delivered is the age. In fluid fusor, since it uses the Marsh as a criteria, as a basic pharmacokinetic model, again, weight is the scalar. In Kataria, again, weight is the scalar. In Minto model, age and lean body mass is the scalar. Okay. So coming on to remifentanil TCI, so you can use remifentanil also as a manual infusion. So that can be done either with 0.5 micrograms per kg per minute bolus, followed by 0.5 micrograms per kg per minute after 3 minutes. So this is proven to have a therapeutic concentration of 6 nanograms per ml. So in order to maintain the same plasma concentration of 2 to 6 nanograms, you can use from 0.08 to 0.25 micrograms per kg per minute of infusion. So only when you use that at this levels will the therapeutic range reach. So in older patients, this therapeutic concentration may be a higher dose, but in young elderly, young individual, this may be an inadequate dose. So you need to be very careful about how you are titrating based on other hemodynamic parameters as well. And in remifentanil, there is a Minto model in which it can be used for more than 12 years or more than 30 kgs. You can still go for both plasma and effect site concentration. The covariates are age, weight, height, and sex. So there, as I told in the initial slides, there are two group of people who use only propofol TCI or those who use propofol versus Remi TCI together. So what do they do here is they induce with propofol. Induction with propofol is basically preferred because remifentanil will act instantly faster, but propofol may not act. It needs some time, 1 to 1.6 minutes time for it to start acting. So the time lag for that has to be given for propofol. So remifentanil, since it will act faster, you can slow it down and then start. So the target Remi concentration shall be 2 to 3 nanograms per ml and propofol shall be 3 to 4 micrograms per ml. There are also other models like Scott model, where which for alfentanil, which requires no covariates, and the therapeutic concentration can range from 3 to 150 nanograms per ml. And Mitre model uses age, weight, and sex for the sofentanil. So, what is the dose of remifentanil or the plasma concentration of remifentanil you are expecting is basically this. So, the TCI dosages, if it is surgical anesthesia, you need to have at least 3 nanograms per ml. So be very sure when you are using remifentanil because when you provide large dose as a bolus, that can result in a chest rigidity and apnea and bradycardia. So you may not be able to ventilate the patient because of wooden chest. So that has to be kept into consideration when you are using any opioids, especially Remi and fentanyl. That can happen quite. That can be quite difficult to treat because you need to have them under with propofol or sedate them more to get the desired effects of relaxation. So for remifentanil, if you need to abolish the intubation response, you need to have 6 nanograms per ml of remifentanil dosages. So if you are going this yellow, no, I mean this blue color, it is associated with increased incidence of side effects also. So better stay with this within this range. So you can, whenever you're using remifentanil TCI, and you need to be careful that you are giving another analgesic agent because the moment you stop remifentanil, the analgesic effects of the opioid is going to wean off. So you need to administer multimodal analgesia before you even think of stopping remifentanil. And another is the dosage of propofol. So when you can use Tiva dosages, this is the nanograms you will achieve. The same for remifentanil also. So if you use this much Tiva dosage, the nanograms you will achieve is 1.32 correspondingly. So you can see this tabular column for even if you don't have a TCA pump in place, you can use this and then find out how much micrograms and nanograms you will need. So for Tiva, again, the TCA dosages is here. So for sedation or moderate pain, you need to have 3 micrograms per ml. So if you need 3 micrograms per ml, give a Tiva of 8 milligrams per kg per hour of infusion following a bolus. So that is how you do it. So whenever you give co-administer, as I told before, start with propofol of 4 to 6 micrograms per ml of propofol. For induction and intubation, you need to have 6 to 8 nanograms per ml of remifentanil to abolish the intubation response. So that was the range. And when the operation is going to start, you need to have a depending upon the level of which you need to have this remifentanil dosage, you can adjust the propofol and remifentanil dosage. So you can stop propofol first, continue remifentanil till the end of surgery, stop it at the end of surgery because this is context insensitive. Since because you feel that remifentanil is going to have a immediate cutoff of its action, you are adding morphine just some 20 minutes prior to the surgery end because the morphine is going to have time to peak effect of 20 minutes. So that is about the TCI. So what are the advantages of TCI is whenever you use it, you will find that the patient is going to be like use it properly after some classes you've attended or some demonstrations you've attended, you will find that the patient is going to be clear-headed, awakening without any like just as they were in the pre-op. And whenever you give it, there is a steady state which is maintained, and hence the hemodynamics is better maintained. So they have found out that there is no hemodynamic instability which will happen because you've given a proper TCI. So there are lots and lots of advantages when you give a TCI alone. And is it without pitfalls? No, nothing is without pitfalls in this point of error. There can be a power failure or a hardware failure or a software bug or an algorithm error or a communication error. You might have told that the patient should be in this much micrograms, but the staff has set it to some other micrograms per ml dosage. So there may be inaccurate delivery the devices. So these infusion pumps are not foolproof. So in ICU, we used to see that we'll keep it as 50 ml per hour, and at the end of 50 and at the end of 1 hour that at least 30 ml will remain in the infusion pump. So there can always be a malfunction in the infusion pump, and the patient IV line, if it is disconnected, the Tiva TCA pump is not going to alert you, and any acute pharmacokinetic changes, it may affect the patient. And sampling errors or assays can happen whenever you're using this Tiva or TCA model. And one more thing to notice, which site concentration you need to have, whether it is effect site concentration or plasma site concentration. So there is lots of studies which are going on as to what concentration you should use. As of now, you can use for Marsh model, whatever it is, like Marsh you can use. For any patient who is young, healthy, well-built, you can go for Marsh model because the scalar used is only weight. For any elderly, frail patient, you can go for Schneider if you have Schneider. But if you're confused as to what model to go with or what is available, what to procure, you can procure Eleveld. So Eleveld is the time-tested one now, and it has been like the universal model, the go-to model. So that is how you use it. If you have March, be very careful when you're using it in elderly patient because the bolus dose which is delivered is quite high and the patient may land up in hemodynamic compromises. For remifentanil, you can use Minto model because that is one which is available right now. We have started to use remifentanil in Tiva infusion pumps, and we always see that they come as if like nothing has happened. But using remifentanil alone is a different ball game because what happens to the implicit memory, explicit memories of the patient that will affect the patient in terms of long term, and awareness is again a issue. And they have found out because of these pitfalls, the patient may land up in inadvertent awareness. So that was reported in NAP5 project. So whenever you decrease the concentration of plasma concentration which you have to administer to the patient, then again that may be associated with an accidental awareness. So it is how you use the Tiva and in which patients you use this Tiva matters a lot rather than your theory of this TCA working by this. So there has been lots of updates in TIVAs and TCIs, and we have got Society of Intravenous Anesthesia also. So that is how rampant it is in the present era. So this session is just an eye opener for you to say what are all the models which are available. And the topic in Miller is really good. And if you want to go read about direct and indirect models of pharmacodynamic models, you can go and read about it. And there is also an article which is there in BJA education. So for principles of intravenous anesthesia. So you can go through that also if you're interested in giving TCIs and TIVAs. So that is about it. Thank you.